Hey guys, Dr. Carmen Bryant here with NursingSchool911.net, and today, by request, we are going to be talking about autonomic dysreflexia. So, autonomic dysreflexia is an issue with the sympathetic nervous system branch of the autonomic nervous system. And the patients who are at risk for developing this life-threatening medical emergency are patients who have had prior spinal cord injuries at the level of T6 or higher. And so it doesn't have to be a recent injury. It can be a 6-month-old injury, a year-old injury, however long, just that level of T6 or higher. And the reason that those injuries at that level cause so many issues is because that's kind of at the level where it innervates that splanchnic bed of arteries. And when that bed of arteries and vessels vasoconstrict, that causes dangerous hypertension in the body. And that's what we're going to talk about with autonomic dysreflexia. So we talked about the patients at risk are those who have had a spinal cord injury at the level of T6 or higher. Here's my little drawing here. So basically it is an overreaction of the sympathetic nervous system to some sort of noxious stimuli, and it is not able to be opposed by the parasympathetic nervous system. So you have the autonomic nervous system, right, which has the two branches, the sympathetic nervous system, which is our fight or flight branch, and then we have the parasympathetic branch, which is the rest and digest. So with this particular disorder, we have a noxious stimuli to happen, and I've written this out BBB to help you guys remember what the most common noxious stimuli are. And this stands for bowel, bladder, and breakdown, for skin breakdown. The most common trigger for autonomic dysreflexia is a full bladder, a distended bladder, that normally that would send signals via spinal nerves up to the brain, that would then send messages to the parasympathetic nervous system, hey, we need to urinate. But with that injury at that T6 level or higher, those messages are not able to be sent out and make it past this level here when traveling down to the bladder or traveling down to the bowel or wherever that noxious stimuli is occurring below that level of injury. Okay, so what we have is let's go with a full bladder. So we have a patient, spinal cord injury, that has a distended bladder that sends a signal which stimulates the sympathetic nervous system to respond. Well, that patient has an injury blocking the signals from the parasympathetic nervous system to oppose that. So what's going to happen is just an overhaul, an overtake of the sympathetic nervous system below the level of that injury. So think about what the sympathetic nervous system does. It's fight or flight. It gets you ready to fight or flight. So the big things that happen are vasoconstriction, all right, an increased heart rate, dilated pupils, all right. So we're going to see all those things happening, but below the level of the injury. So below the level of the injury, and I mentioned that splanchnic bed of arteries, those are going to vasoconstrict and cause massive hypertension. Okay, so that is obviously the most dangerous manifestation of autonomic dysreflexia. Okay, so also you got to think about what's going on below the level of the injury. So you have that vasoconstriction that's responding to signals from the sympathetic nervous system. Well, what else happens when our vessels vasoconstrict? It shunts blood away from the skin. Okay, so the skin below the level of the injury are going to have, it's going to be pale. clammy, cool to touch, because that vasoconstriction is, shunting blood away from the skin below the level of the injury. So as a result, that's what's going on down below. Then above, you still have the parasympathetic nervous system trying to do its thing, right? Trying to fix this hypertension, because you have baroreceptors that sense pressure changes. Okay, and those are located on the aorta, the carotid sinus, and those baroreceptors are sensing, hey, there's some dangerous hypertension going on. So those baroreceptors are going to try to intermediate and try to send signals to lower the blood pressure, to cause vasodilation and things like that. But it's not going to work, okay? Unless you're looking at the patient above the level of the injury, okay? So those parasympathetic impulses will result in vasodilation above the level of the injury. And we'll talk about all the signs and symptoms here in just a minute. But one of the other things that you'll see is the bradycardia, all right? So the vagus nerve is the main, cranial nerve that is innervated, that, helps us regulate heart rate. And when it is stimulated, it lowers the heart rate. Okay, so the brain is still able to communicate to the vagus nerve. And so those baroreceptors sense that change in pressure, tell the vagus nerve, hey, let's slow down the heart rate to try to get this pressure down. So you're going to see massive, massive hypertension. And I want to preface this also by saying our spinal cord injury patients, they typically have a much lower, just kind of baseline blood pressure than the general population. And so a blood pressure of 130 or 140 systolic could absolutely mean that our spinal cord patient is experiencing autonomic dysreflexia. So anytime we admit someone with a high level spinal cord injury, always get that baseline blood pressure. Ask them, what does it normally run for you? Because most often they're going to tell you, hey man, my blood pressure typically runs like 95 systolic. Okay, so what we would normally brush off in a normal person, like, oh, their blood pressure is 145 over 85, they're fine. No, in a person with a spinal cord injury, a high level spinal cord injury, that is absolutely not fine. Okay. So we have that dangerous hypertension. We're going to have that reflex bradycardia because of the baroreceptors and because of those signals being sent to the vagus nerve to stimulate that vagus nerve. The patient, the first thing that they might complain of or report to you is a headache, because think about what's going on above the level of the injury. Massive vasodilation. Okay, so blood is rushing to the patient's head, and they may report to you, man, I've got this really bad headache. Check their blood pressure. They might also have some nasal congestion, and so again, this is above the level of the injury, and this is simply just an effect of an overreaction of the parasympathetic nervous system above the level of that injury. So that's a very common manifestation of autonomic dysreflexia, is a stuffy nose, nasal congestion that wasn't there before. Okay, diaphoresis above the level of the injury. Again, that massive vasodilation, that's what we do when we're trying to cool ourselves down. So you would see diaphoresis above the level of the injury. And then also flushing, as a result of that vasodilation. Again, I've got up arrows because that's above the level of the injury. And then again, blurred vision. So they may report some blurred vision, because of that massive hypertension, because of that headache or whatever. So, the moral of the story is you have this patient that's at risk for autonomic dysreflexia. It is absolutely a medical emergency for these patients. If they report a headache, your very next action is to assess that blood pressure and let's see what's going on. Are they actually experiencing autonomic dysreflexia? So What are we going to do about it after we've determined, yes, this patient is experiencing this medical emergency? The very first thing we're going to do is raise the head of that bed up 90 degrees, high Fowlers, to get that venous drainage and get that blood pressure down. Dangle their legs, off the side of the bed. If they can't do that, there's sometimes you can put those beds in the chair position, but most importantly, raise the head of the bed first, okay? Loosen any restrictive clothing, any restrictive devices, do that for them. Then we're going to go ahead and start investigating the cause, right? Because first we've got to intervene and make sure that no serious potential complications result from this dangerous hypertension. Okay, so get the head of the bed up, loosen restrictive devices. Patient safety, patient safety. Then we're going to investigate those causes. So we're going to check the bladder. If they don't have a Foley catheter in, go get a bladder scanner, scan the bladder, palpate the bladder for distension. It may be that they need a Foley inserted. If they do have a Foley inserted, look at the bag. Is it draining? Are there kinks or loops or something going on with the Foley that is causing it to be backed up and not drain properly? We're going to check the bowel, for distended bowel. There may be a fecal impaction or something like that. Ask the patient, when was your last bowel movement? Bowel sounds, are there bowel sounds, going crazy and they haven't had a bowel movement in a few days. So it may be that we need to, do a suppository or something like that. We've absolutely got to reverse the cause, right? And we're going to check the skin. I mentioned skin breakdown. So we're going to look for any, pressure injuries or anything like that on their back, because those are, these are patients with spinal cord injuries. And so they're always at risk for developing those pressure injuries. So we're going to check for that, because those pressure injuries or anything, poking them in the back, they may be laying on, a needle cap or something, So after we've checked the most common cause, which is the distended the distended bladder, then the bowel, then move on to, the skin, are they laying on something that's causing them pain in the bed or something like that. Always want to think about prevention with these patients, right? So when these patients come in, we know they've got a high level spinal cord injury. Always want to get that baseline blood pressure, because you always want to be a proactive nurse, right? You want it in the back of your mind, hey, I know this patient is at risk for autonomic dysreflexia. It may be that they're admitted for an infected pressure ulcer or something like that, but in the back of your mind, okay, autonomic dysreflexia is definitely a possibility for this patient. So I want to go ahead and assess what their baseline blood pressure is. You want to make sure that if they don't already have a pressure injury, that they don't incur one during their hospital stay. So we're going to keep them turned at a very minimum of every 2 hours. We're going to make sure that they're emptying their bladder, I's and O's. So prevention is key when it comes to autonomic dysreflexia. So then detecting and acting on, when the patient does start displaying those signs and symptoms, as we've just talked about, the action of raising the head of the bed, loosening the clothing, and then trying to find the reversible cause and reverse that cause. So let's say we've done all the things. We've raised the head of the bed up, we've loosened everything that we can loosen. We cannot find anything wrong with their bladder, bowel, or skin breakdown or pain or, anything like that. Then we're going to have to move on in with medication and treat their hypertension with medication. The most often ordered medications are going to be nifedipine, which is a calcium channel blocker. It's a vasodilator, and obviously nitrates, which are also vasodilators as well. We are going to continue to monitor this patient's blood pressure at least every 5 minutes for at least 2 hours, okay? When their blood pressure consistently reads, you know, their normal, which is typically 90 to 110 systolic, then we can, you know, consider it resolved. But we're going to continue to monitor blood pressure no matter what the blood pressure is, every 5 minutes for at least 2 hours, okay? Until we reach that number that we're happy with, all right? So that's about it for autonomic dysreflexia. I hope that this video has been helpful to you guys. I hope the semester is going well. If you're about to take NCLEX, good luck. You're going to do great. Just make sure you look around on the website for more, you know, resources. There's infographics, there's complete care plans that's going to come in handy for clinical. There's a few other videos, and I'm adding videos, you know, as I can weekly. So again, thank you guys so much for watching, and I hope the rest of your semester goes great.